Hello, everyone. We're letting people make their way in from the waiting room, um, and we'll give it just a little bit before we get officially started. I still see that number climbing, so we will give it just one more moment here. All right. Since we are one after, I will go ahead and get us started. Um, Welcome, good morning, and good afternoon to everyone, and thanks for joining us today. My name is Lauren Westland, and I'm the Senior Manager for this new HCM System of Care initiative. We're thrilled to welcome you all today to learn more about the American Heart Association's Hypertrophic Cardiomyopathy Registry powered by Get With the Guidelines. This is an exciting milestone, and we're looking forward to sharing with you what we've been working on and where we're headed together. The HCM registry, this HCM registry represents a significant step toward improving understanding, treatment, and outcomes for individuals living with HCM. And next, we'll go over a few housekeeping items. Please note that this meeting is being recorded and the recording will be archived on the HCM registry website. Also, we would ask that you please remain on mute unless you're asking a question. We recommend that you submit your questions in the chat and they will be addressed during the Q&A portion at the end. We thank you in advance for your attention to these items as we go along today. During today's webinar, we'll hear from two incredible leaders, Dr. Andrew Wong and Dr. Anjali Owens, who serve as co-chairs as the initiative's HCM Scientific Advisory Group. Dr. Wong is a professor of medicine at Duke University Health System. He is the director of the Duke Hypertrophic Cardiomyopathy Clinic, and he serves on the board of the HCM Society. Dr. Anjali Owens is the founding director of the Center for Inherited Cardiovascular Disease and director of the HCM program at the University of Pennsylvania Perelman School of Medicine. She also serves on the board of the HCM Society. They are both recognized leaders in the field, and we are thrilled to have them joining today to share their expertise with us. Next slide, please. Throughout this hour, we will explore why hypertrophic cardiomyopathy matters, the challenges clinicians and patients face, and how this registry is designed to help address those challenges. We will introduce the registry, its aims, and how it came to be. We will also hear from Jason Walchuk, who is the AHA National Director of Health IT, who will give a registry overview and the benefits of participation. And lastly, how your organization can get involved. We will end our session today with a Q&A. We are excited to begin this journey with you, and we're so glad you're here. Let's get started. I will turn it over to Dr. Wong.
Thanks very much, Lauren, for the introduction, and thanks to the AHA for developing this important registry. And I want to thank all the attendees for your interest in this. My goal in the next few slides is to talk about why knowing and treating hypertrophic cardiomyopathy matters more than you think. Next slide. A simple way to describe hypertrophic cardiomyopathy is that it is abnormal increased thickening of the heart muscle wall in the left ventricle. And as a result of that increased heart muscle thickness or hypertrophy, it leads to abnormal relaxation, which can make it more difficult for blood to fill the left ventricle, and in some cases can cause obstruction for blood to exit the left ventricle. Hypertrophic cardiomyopathy used to be considered a rare disease, but now is recognized as one of the most common genetic cardiovascular diseases. Throughout multiple different studies using echo to study the epidemiology and prevalence of hypertrophic cardiomyopathy, it's been found to affect 1 in 500 people. So in the United States, that would be approximately 700,000 people who have abnormal heart muscle thickness that would be consistent with hypertrophic cardiomyopathy. In larger genetic general population studies, the prevalence of an abnormal gene variant that is known to cause hypertrophic cardiomyopathy is actually even more common than that, 1 in 200. And because it is an autosomal dominant inheritance pattern, that means first-degree relatives are at 50% risk of being a genetic carrier or developing hypertrophic cardiomyopathy. Again, estimated 700,000 people in the United States have hypertrophic cardiomyopathy, but only 1 in 7 is diagnosed, meaning that the condition is often underdiagnosed or delayed in diagnosis or misdiagnosed. The hypertrophic cardiomyopathy condition is a chronic, lifelong condition, although we do have new treatments that improve the outcomes of these patients. Next slide, please. As I mentioned, it affects all genders, all races with the same prevalence. It's found throughout all regions of the world. Some of the major complications that patients may develop with hypertrophic cardiomyopathy include a risk of ventricular arrhythmias and sudden cardiac death, a risk of atrial arrhythmias, specifically atrial fibrillation, and risk of stroke associated with that, and diastolic heart failure. Next slide, please. The clinical course for patients with hypertrophic cardiomyopathy is variable. As I mentioned, there are very severe complications that can affect a patient at any point in their lifetime, including the risk of sudden cardiac death, progressive heart failure, either in the setting of obstructive or non-obstructive hypertrophic cardiomyopathy, and arrhythmias, including atrial fibrillation, and a much higher risk of stroke associated with atrial fibrillation. Next slide, please. Some patients have no adverse pathways. This comes from a large cohort study of over 2,000 patients followed long-term, and a high percentage have no adverse pathways, but more than half of patients with hypertrophic cardiomyopathy develop significant complications. The most common complication was worsening heart failure symptom that was much more likely to happen in patients who have the obstructive, more common form of hypertrophic cardiomyopathy, but also can affect those with non-obstructive hypertrophic cardiomyopathy. Atrial fibrillation is common, especially as patients with hypertrophic cardiomyopathy are living longer, and the risk of sudden cardiac death, although small, is the most serious of complications for these patients. Fortunately, we have very effective therapies to improve the outcome of patients with hypertrophic cardiomyopathy. For treating heart failure symptoms, we have medications. We have septal reduction therapies for those that have symptomatic obstructive hypertrophic cardiomyopathy. And for those that develop worsening left ventricular function or refractory heart failure, heart transplantation is an option. For managing atrial fibrillation, as many of you are aware, we have antiarrhythmic drugs to maintain normal rhythm. There's ablation to manage atrial fibrillation. And very importantly, anticoagulant therapy is very effective for reducing the risk of stroke that can occur as a result of atrial fibrillation. And finally, for the most serious complications, sudden cardiac death can affect a patient at any age with hypertrophic cardiomyopathy. The only therapy that's been shown to reduce the risk of sudden cardiac death is an implantable cardioverter, defibrillator, or ICD. Next slide, please. As a result of these contemporary effective therapies, the outcome of patients with hypertrophic cardiomyopathy has significantly improved over different time eras. You can see here the HCM-related mortality, meaning death due to heart failure or arrhythmia or sudden cardiac death over time, has really improved to the more contemporary shown in the orange bars there, where the annual risk of mortality for patients with hypertrophic cardiomyopathy with effective treatment is less than 1% and generally about the same as the general population. So these therapies are very effective when used appropriately. Next slide. We also have guidelines. The American Heart Association, American College of Cardiology guidelines for the evidence-based appropriate treatment for patients with hypertrophic cardiomyopathy. From many, many studies, we have developed this evidence base to say what is the best way to treat patients with hypertrophic cardiomyopathy to improve their outcome. The guidelines for managing HCM have undergone very rapid revision and updating. It was revised in 2020, and just 4 years later, last year, it was revised again because of important advances in the treatment of hypertrophic cardiomyopathy. Next slide. Within the guidelines, this is a table from the guidelines. It highlights all the important resources that a patient with hypertrophic cardiomyopathy may need to help them over the course of their lifetime. You can see the list there, and it also differentiates the levels of centers or the types of different healthcare settings in which these patients with hypertrophic cardiomyopathy will likely receive care, from comprehensive HCM centers to primary HCM centers to referring centers and physicians. And at each level, there are important resources that need to be available to help treat these patients effectively. Next slide. So I'm going to turn this over to Anjali to talk about really the purpose of this registry, which is really to improve the quality of the care we provide for patients with hypertrophic cardiomyopathy, first by assessing the quality of care and then hopefully making significant improvements to optimize their outcome. Thank you very much.
Thank you, Dr. Wong, and thank you to the attendees for joining us today. It's a real pleasure to be here and a pleasure to see so many people joining during their day. Over the next few minutes, I'll introduce you at a high level to our plans for the AHA HCM registry. So why do we need this registry? You've heard from Dr. Wong the potential complications of this disease, and we really need to build an HCM system of care to be used for our patients. Our current systems of care remain both variable and fragmented throughout the United States for patients with HCM, and there really is an urgent need to standardize how our patients are identified, assessed, referred, and treated. To address the gaps in identification and treatment standards, the AHA registry will develop a national recognition program which focuses on evidence-based measures to ensure the highest quality care. We will develop treatment standards within U.S. sites that are treating HCM patients. And finally, importantly, a collaborative to understand treatment patterns, identify best practices, create data and measures that support recognition and certification. Next slide. If you put those needs and purposes together, our mission statement became fairly straightforward: to better understand contemporary clinical management, treatment patterns, and outcomes in patients presenting with hypertrophic cardiomyopathy to healthcare settings across the United States, and to simply improve the quality of their care. Next slide. We have developed a deeper set of core scientific aims, and I will share them with you here at a high level. The first is to characterize the natural history, epidemiology, and clinical management of HCM. By establishing a national HCM registry, it will allow us to systematically collect and analyze data with regard to patient identification, clinical presentation, diagnostic strategies, treatment patterns, and outcomes across a diverse healthcare setting. It will allow us to investigate changes in natural history of HCM as we utilize contemporary medical interventions and newer therapies. It will also allow us to examine variations in outcomes across demographic and clinical subgroups. Aim number 2, to assess the impact of contemporary medical interventions and novel therapies on long-term outcomes. We will utilize registry data within this aim to evaluate adoption trends, safety, and effectiveness of standard and emerging therapeutic approaches. We will be able to explore their influence on morbidity, functional status, survival, and quality of life over time. The third aim is to identify and address disparities in access to advanced HCM care and therapies. We will be able to quantify regional, socioeconomic, and global disparities in access to specialized HCM care, advanced therapies, and newer treatment options. We will hopefully be able to develop strategies to improve equitable care delivery and to reduce barriers to high-quality treatment. Our fourth aim is to develop, validate, and implement HCM-specific quality metrics. We will define and pilot evidence-based measures for HCM recognition and certification to standardize adherence to our guideline-directed care. We will be able to promote best practices to enhance patient outcomes and optimize care pathways. And our final aim is to advance the research, translational science, and health policy within hypertrophic cardiomyopathy. We plan to leverage the registry data to support clinical, translational, and implementation research. This will hopefully foster a study-ready network to drive innovations in diagnostics, therapeutics, and long-term disease management. We hope that this will provide evidence to inform and guide health policies and to improve patient care and resource allocation. Next, I'll pass it along to Jason, who will dive a little deeper into the platform of the registry.
Thank you, Dr. Owens. I appreciate it. I'm going to take a tour, just a kind of a walkthrough of the overview, the concepts of Get With The Guidelines. Some of you that are participating on this call today are aware of our registries that we have in many different disease states, our quality programs, and the all-encompassing platform in which we provide to hospitals to do quality improvement care. Others, this may be the first time you're seeing this, so we want to kind of start at the beginning and look a little bit at a higher level of what the American Heart Association provides for our quality platform and what hospitals are currently using it for. So Get With The Guidelines and the registries that we provide as the AHA provide a suite of tools for hospitals to participate within our programs for recognition based on quality of care provided on a specific disease state, supporting certification, and also promoting centralized use at a health system or a hospital for research, as well as contributing to the national analytic data set that could be used for further evaluation and research. The primary registries within our suite are the heart failure, stroke, AFib, coronary arteries, and recess. We've been in existence with the Get With The Guidelines platform for over 20 years. We moved into more of a novel registry, kind of the genesis of the COVID registry during that time period. Since then, we've built the cardiogenic shock registry, the aortic stenosis registry, focusing on other specific cardiovascular diseases. And we also have a suite of outpatient registries focused on diabetes, check change control cholesterol, and target BP. Our registries are in over 2,800 hospitals across the country. Chances are, even if you are unaware that your facility or center may participate in one of them, you may for one of the disease states. We cover about 80% of all stroke discharges within the United States and access to the registry by over 80% of the population. And what do hospitals and centers and health systems use our registries for, and what we're kind of bringing to bear for the HCM population is that our registries are not just a data collection tool, whereas in some research projects, you're provided with a set of specifications to collect raw data that's then contributed to a larger database for analytics. The American Heart Association takes the approach that the data is entered into the system to provide outcomes to you first before we have access to it or use it in the analytics. Therefore, you can enter data in to help support your certifications, state or regional initiatives, any local research. You can create custom fields and all types of data collection right within the platform, along with the American Heart Association data. We use it to support clinical trials, grant-funded projects, a lot of other initiatives that are ancillary that we can actually use this tool to help support it. So hospitals use our tools to build measures, reports, collect data in a structured way so that they can use the tools right within the platform to do meaningful quality improvement on that specific disease state. You'll see in a little while, we'll go through a little bit of the reporting and abilities to look at fallouts and areas for improvement and to drill into each of those patients to really provide your providers and your quality teams with meaningful data to perform their duties. The data collection within all of the Get With the Guidelines modules is chart abstracted. However, we do partner with a number of compatible vendors that are available on our website. With this specific project for hypertrophic cardiomyopathy, we are in discussions with some AI and other current compatible vendors where they will make offerings to hospitals to help facilitate data extraction and submission within the Get With the Guidelines tool. So these are the three primary methods: manual abstraction, which is chart abstracted either through a third party or hospital staff; compatible vendor, if you use vendors such as Premier or Cedar-On or Lumetics or any of those existing ones that are out there that support our registries, you will be providing opportunities for them to help facilitate data submission to this registry, the same as our others. And then also, we have a slew of hospitals across the country that leverage their own health IT departments to create extracts out of their EMRs, map it to our data standard, and submit it into a uploader file right within the front end of the registry. All of our systems have that available right on the front end, so you can create records at will, you can update records, you can upload records. All of that is standard in all of the user interface and access in all of our registries. So the HCM registry specifically is designed to help facilitate more of a streamlined data collection, whether you're using a chart abstracted model or you're uploading records to get things started and finishing behind it with some manual abstraction. There's logic-based abstraction and data collection within the form. And what that means is only pertinent variables for that specific patient will downline, open up, and become available for you. It really does streamline the data form and make it simpler and easier to digest as you're abstracting. We will have full PII data collection available, as we do in all of our modules. This provides an opportunity to use that personal identifiable information to create a unique ID for linking of these patients across our registries and also across institutions within the HCM registry as well. There is a multiple form. We'll kind of go into that in a minute. That's how we're going to be capturing longitudinal tracking of patients. There'll be a one form that will be completed every 12 months on the patient that will evaluate the care and testing and things that were done on that patient in the previous 12 months. We were also going to provide tools such as a summary dashboard and login, so you can kind of get a good snapshot up to date every 24 hours of the patients and data within the registry, as well as providing you with list reports back to show you what patients are potentially due for follow-up for certain testing. Again, we want to provide a platform to you that you're not just putting data into, but it's providing meaningful feedback to you to help you manage those patients within your centers. There's always a raw data extract and customizable list reports that will be available to you. And we'll get into that further into training and also a little bit later into this webinar. So the patient entry criteria, the patients that we're seeking for entry within the registry are patients greater than 18 years old with a clinical diagnosis of HCM and primary or secondary ICD code of HCM. We want to exclude any patients less than 18 and patients that are not diagnosed with cardiomyopathy. So it is rather broad, but it does include that clinical diagnosis with the ICD-10 code. The data collection, there will be a CRF available for those that want to review it. Understanding that, again, the data collection is based on the previous responses. Therefore, if you go to complete a form and a patient, within the last 12 months had an office visit, maybe a follow-up echo, those would be the only two sections you would answer. So the form can look kind of long when you look through it, understanding with that form logic. But in general, the administrative form is going to capture the demographics, the assessment, the encounter date, those types of things. Medical history will be handed over from form to form, so you can evaluate it. It'll be pre-populated from the previous form to save and decrease abstractions. Same with medications. The areas of importance based on the clinical guidelines that were just presented on: atrial fibrillation management, more advanced heart failure, clinic office visits, which includes your AFib screening, genetic tests, and sudden cardiac death assessment, We have an echo section, an ICD placement, SRT sections to capture pertinent data available within those if those treatments were provided to the patient. We also have a discontinuation section, understanding that patients do move from one location to the other, having the ability to end that form for that patient if you're no longer caring for them at your center, and or getting outcomes for those patients via that discontinuation end form. So to simplify this down, the way that the data collection is designed within the HCM registry for AHA is that initially upon entering a patient within the registry, you're going to have a demographic form that you'll complete for that patient. It has pertinent things such as their diagnosis, when did it occur, what type of diagnosis, certain attributes related to maybe any previous treatments that they may have had, or assessments. And once that demographic form is created, that patient is then entered into the registry, and now you're able to create encounter forms off of that patient. The requirement for the abstraction for this is a 12-month review. So after that initial data entry in the encounter form, it would be 12 months from that day. You would then do another form, and we'll provide a report within the system to let you know when those patients are coming up due for reabstraction. You'll complete another review for the 12-month window from the last assessment form to the current one, and enter in any treatments, assessments, or care that was provided. So you can see at the top, the initial one, they had an echo and a cardiac MRI. 12 months later, we do a review of the chart, and we see that they did a follow-up TTE, and they also had a 12 lead. So those two sections are completed in the new form. That form is completed, and that patient is now evaluated for that 12 months. The next time you'd go in to evaluate them again would be another 12 months later. Any number of forms could be created off of that patient. So as the years go on, you can continuously keep adding on additional forms as assessments and things occur. If any of you have not seen our registry platform, this is just a quick overview screenshot of it. It is an interactive web-based system, so there's nothing to install on-prem. There's nothing to put within your system. It is a URL that you get access to with your own credentials for your individual facility. You can have a number of users in it. All data that's abstracted by any abstractor at that facility will be available to all other abstractors within the system. Records are entered in via that patient tab. You can see the workflow here, nice clean flow of how to abstract. The tabs on the right-hand side will take you into each section of the form. Different tabs will become available based on what treatments we said that the patient had provided to them. There's also, as you can see on the left, areas to upload. You can manage the form, add custom elements and all types of things that you want to have at your facility. Also operational reports, and we also provide a full library of all the resources, specifications for upload, documentation for coding instructions. All of those things are all available right within the UI here. So one big important emphasis for the American Heart Association is our focus on quality, is that data collection extremely important and accurate. We need to provide tools and resources immediately back to the hospitals and the centers to use that data for quality improvement. And so one of the things we pride ourselves on is in the analytics and the tools that we provide back to our customers. And those include configurable measure reports. There will be rate-based descriptive measures, also the ability for you to filter out data so you can run certain quality metrics that the volunteers will create within the system and filter them by diagnosis, race, age, do distributions by pay source, and all types of different analysis you'll be able to do right directly within the Get With The Guidelines system without having to extract that out and put it into another tool that you may use. We're also going to provide a number of patient list reports specifically for HCM so that we can look at that longitudinal review of the patient, of seeing where they are within the guidelines of adherence to evaluation timelines and treatments. And then also that report that we're hoping to provide to help you abstract these patients kind of at a normal cadence is a patient's needing follow-up. Patients that are starting to fall within that 12-month window that they're going to need a reabstraction within the registry itself. You also have a data download report, so all data that you put in, you can get it immediately back out. There's also a number of derived variables that we use the data within the system to create and derive our own. You get those out as well, so you kind of get more out of it than you put in. And then there's also benchmarking, which is extremely important to all of our hospitals and health systems. This is the ability for you to run those metrics and configurable measure reports and then also benchmark and show your comparators to your state, your region of other hospitals and centers that participate with it in the HCM registry. So you can kind of see where you measure up, where you have opportunities. And also with that, you also get an aggregate for the state and the region and everything in the country right within the system without having to request that from somewhere else. You can go in and run that at any time you want. This is a screenshot of just the UI, the user interface that we have for our reports. This is our cardiogenic shock registry as we're building out the HCM reports. But you can see these are, distribution measures of running measures over a period of time. There's a lot of customization, filtering, comparators, and things that we can add into this as you run the report, kind of just like an interactive dashboard. Customers do seem to like this a lot, that they use these for presentations and to really drill down and answer questions that maybe their investigators and physicians come to them with, leveraging the data. The other reports that we're talking through is these patient list reports. So this is an example you see down here at the bottom, a simple list report with variables and calculated measurements along the axis there of each column. So as I said, for HCM specifically, because of the nature of the multiple treatments and the longitudinal review of these patients, we're going to provide opportunities for reports to look at follow-up for echo and testing, patients that require that chart review, so around that 90-day piece of that 12 months to show you and flag those patients so that it's easier for the abstractors to acknowledge to go in to do the next form on that patient. Patients with missing encounters, testings based on the guidelines frequency. So we're really trying to provide, again, tools to you so you can go in and manage your patients right within the system to make it more meaningful of the data that you enter. A couple things that often come up, and so I like to touch these just at the end of this part of the presentation, is interoperability. So there are ways where hospitals and our compatible vendors have found solutions to extract data out of your EMR and provide that data to the American Heart Association. So a number of sites, again, you may not know if your hospital actually participates in Get With the Guidelines. You may want to reach out to your quality improvement or quality department or any of the abstraction services that you use and see if you participate in any of our stroke or CAD registries. If you participate in stroke, there's a chance your hospital is already leveraging an extract built to our specs to upload within the system. You can maybe leverage some of that work done to harvest some of these data that are going to be needed for our registry. But we do provide full specifications of the registry, an upload manual, and all the documentation needed for your health IT department to map your data to our standard for upload within the system. Compatible vendor is also another option. We are diligently working as we're building out specifications for the HCM registry to find vendors that are specific within that niche that could provide these services. And we've already had a few conversations with them, and more will come on, and we'll make those available on our website of who is working in that space and has our specifications. I highlighted the AI-assisted abstraction because this is something that comes up a lot. We are in conversation with a number of vendors, again, that we're providing specifications to so that they could provide this type of service to hospitals and centers. AHA doesn't do this, but we do, work with vendors that potentially could offer these types of solutions. So as these kind of pan out and we do some pilots, we'll make that available, obviously, to customers as well. And then also, we do have some expertise in-house to help create file converters or transformers utilizing standardized formats. So if you participate in an HCM registry of one kind, if we have those specifications, we can create converters to alter that file to make it compliant to our specifications for then return upload within our system. So we're looking forward to that. We have some opportunities there with some existing HCM data sets that we look to make available as in a converter in the future as well. So these are all things that are in the works right now. Just kind of want to spotlight that. And again, the way the compatible vendor works, because we get this question quite often as well, is that there are a number of services or companies that provide this type of platform to customers. So we will make those companies available on our website of who starts signing up and getting our specifications. The hospital EMR and EHR will connect to that via that agreement with you and that vendor, but the vendor has our specifications, so they then could produce a CSV file or submit that data via an XML into our registry. This is not required. I will tell you that the vast majority of our novel registries are chart abstracted. It's a user that goes in. They may upload data to begin the demographic data, because you could do partial uploads. You could multiple uploads for one patient if you wanted to. There's no limitation to that. All of those create the records within the system that you then can navigate through and answer all the questions that are left out of the file that you uploaded from. So there's a number of hospitals that kind of do a mix of that, thousands of hospitals that do that. So that won't be an exception in this case either. But wanted to cover all of those pieces, and I look forward to any questions you all have. I'll be on, and hope to see you all on future trainings when you join. Thank you.
Thank you, Jason. And thank you to Drs. Wong and Owens for the fantastic overview of the registry and its features. So how does your site participate? We go to the next slide, please? As a next step, we're asking all interested sites to complete the JOT form that can be found on the HCM registry website, which is listed there on this slide. And this is an important first action. It allows us to officially note your interest and begin tracking participating sites. Once your interest is submitted to us, a member of our team will reach out to you directly to guide you through the contracting process. For those of you who are brand new to Get With the Guidelines, participation in the HCM registry will require a unified participation agreement. And if your organization is already a member or customer, you will simply need to sign an amendment to include participation in the HCM registry. So that website again is theheart.org/HCM registry. And next slide, please. And you can also contact us. Our team is here to help at every step. If you have any questions at any point about any aspect of the registry or the process to join, please don't hesitate to reach out. Our contact information is provided on this slide. That website URL again is there, along with the email that is hcm@heart.org to reach out with any questions. The QR code on this slide directly links to that JOT form that was mentioned earlier, and it will take you directly there to express interest. And with that, we will now open it up for Q&A, and we can start with the items that people have put in the chat. And I believe the first few were for Jason. Does the discontinuation form discontinue the patient entirely, or if they move somewhere else, are the current providers able to pick up and continue within the form?
Yep. It's a great question. The registries that we have are site-based, so the data that's collected from each center is of the perspective of that individual center that's providing the care. So if a patient is no longer seen by them, so if they move across the country, they can, basically close that patient out by discontinuing. The next center, if they're participating in the AHA registry, they would pick them up from there. Later, just on the analytics side of things, we can link that patient through the master patient index, utilizing that PII and that random unique ID later after. But because of the constraints of our unified participation agreement, we can't share that data with two separate centers that are across the country from one another. So yeah, it's the perspective of you when you start caring for that patient.
Thank you. And one more looks like for you, Jason. We do participate in the stroke registry, but I don't believe we have anything coming from our EMR. Do you pull data from Cerner?
So AHA doesn't pull data from anywhere. We provide the registry platform, and then we support and give specifications to vendors that may provide those solutions and platforms to customers. So I am aware that there are Cerner customers out there that are building extracts either by their health IT department to map to our data to be uploaded within the registry. We can, get your name. We do connect facilities and health systems with each other sometimes. that they could help, use shared knowledge to come up with those solutions between themselves. So we could get her info. We might be able to connect you with another Cerner site that's doing an extract.
And then this next question is about the inclusion criteria. Mention that patients must be 18 or older and have the primary ICD code. Is that a part of an inpatient stay or any outpatient visit?
So this registry is not based like our other inpatient modules on admission. This is a HCM center that is caring for a patient. They may never have an admission. So it's just patients within your care that we're looking for. And Dr. Wong, I don't know if you have any more way to emphasize that, but there's not a requirement for an admission of any kind to be entered into the registry.
That's correct. It would be both inpatient and outpatient. Generally, for most of these patients, it would be outpatient data entered.
Thank you. And is the registry considered a clinical trial with a national clinical trial number? Are sites required to get IRB approval to participate? And I think Shayna Costello was gonna address this
Yes, and I
one.
saw we just had another question come in too about IRB approval. So no, this is a quality improvement initiative. So it is not considered a clinical trial and therefore does not require IRB approval. However, that being said, we understand that institutions have their own requirements for IRB. So if that is something that does need to come from in order to have an IRB approval, then of course we are happy to help with the information that you need to submit that.
Thanks, Shayna. Where can we review data elements this registry will collect?
So as the CRF, which we have, the volunteer group here and the science advisory group and a CRF registry work group. The CRF is near final. We actually have the platform basically in our highest testing environment right now. So as that CRF is really put together, we will be making it available on the website and through Shayna. So if you have any questions and you would like those materials, the best thing to do is to reach out via those links that Lauren shared to get information and we can get those to you.
We already submitted the Connect form. When would we expect to hear back on next steps? We will be in contact with you if you have reached out. We will provide updates as we move forward, and you should receive something back from us shortly. Can the new provider see everything that was done with the patient at the prior facility? I'm mainly asking about long-term tracking of specific patients.
Yeah, and the design of our registries again is, based on that site's perspective of abstraction. So you cannot see the data from the other facilities within the system. You'll abstract that data based on your care. Initially, when you onboard a patient, or maybe you enter the patient for the first time and you've cared for them for a period of time, you'll see that there is a historic area where you actually could document any previous treatments and things that the patient did provide or already had in the future, and you can collect the dates of those, as well as in the history for each evaluation, we'll have medications and also past procedures where those can be documented in there as well. And that is longitudinal. So those will be carryover from form to form, but not facility to facility, no, within the system. So I hope that helps answer that question.
Is payer information part of abstraction? Adding the details to registry.
Payer is, so pay source is a standard variable within the system. So yes, that is captured.
Does this registry require medication monitoring for HCM?
No, it does not. It is going to collect data regarding what treatment the patient receives for hypertrophic cardiomyopathy, but there's no protocol or sort of requirement for any specific treatment or monitoring on their medications.
And a patient may not be on any medications, completely asymptomatic with HCM, and we would still want to capture their data as part of the registry. We really want to look at the whole spectrum of disease over time.
Thank you. Would hospitals initiate patients into this database, or is the intent for HCM centers to enter patients into the database and also capture any hospital admission info if an admission occurs?
Just from the data collection side, I could just speak real quick, and then I'll hand it to Dr. Wong, is the data collection form itself, that 12-month review, does include an area for any in-hospital admission, as well as the outpatient components of a clinic visit. So the form is all encompassing. So the person that is abstracting that would need to have access potentially to the inpatient data, as well as any ambulatory or outpatient data on the data collection side. How they break that up in abstraction, if it's one person or another, that's completely up to you. But Dr. Wong, if you have anything else to add.
Yes, thank you, Jason. So as Jason said, we do want to collect HCM-related hospitalization. So if someone gets admitted for atrial fibrillation and they undergo an ablation, we do want to capture that. We don't have to capture it immediately upon discharge. It would be as part of their routine follow-up in the outpatient clinic, where we would collect, this patient was admitted, they had a ablation for atrial fibrillation, we would collect what medicines they're on and how they're doing with regard to their symptoms. But it'll all be part of routine care. It does not need to be entered immediately upon the event happening, more of a historical perspective.
And we may learn more about how different health systems have their inpatient and outpatient care set up. And that may be one of, the variable aspects of care in HCM in the US, is that some health systems have integrated inpatient and outpatient care. Others may have inpatient care at a separate center from their outpatient clinics. And so some of that information may be variable, and we'll learn about the treatment patterns by developing the registry.
Then it looks like, what are the main metrics you will collect for this QI, or how are we going to be measured?
So there is a certification and recognition committee that is developing the criteria for both certification and recognition, meaning achieving a certain level of quality. Those metrics are still to be defined. With regard to the data that is collected in the case report forms, our goal really is to focus on the guideline recommendations for what is a class 1 recommendation for treatment, what is a class 3 recommendation for that should not be done, and really to make sure that we are providing feedback to centers about their treatment patterns. For example, for patients with hypertrophic cardiomyopathy who develop atrial fibrillation, a very important quality measure would be what % of patients are treated with an oral anticoagulant to prevent a stroke. So that's an example where it's a class 1 recommendation in the guidelines that regardless of the CHADS VAS score, they should be treated with an anticoagulant if they have an acceptable bleeding risk. But how are centers performing in that regard is an important metric. I hope that answers the question.
Yeah, and I was just going to add to that, Dr. Wong, that eventually there will be a QI recognition award, and all of those measures, like Dr. Wong was just saying, are under development. So stay tuned for more information, but that is part of what this initiative will be adding in the AHA recognition umbrella.
And I would also like to add that if you want to request to come off mute, since everybody was muted upon entry, and ask a question, please do so, and we can unmute you if you would prefer to ask instead of typing in the chat. Otherwise, I don't see any more questions in the chat. And if nobody else has anything they want to add.
I'm just
Anything
going to add to, I saw another question come through about if there's any financial support for sites in this initiative. And I just wanted to share that with the group too, that there are limited spots to enroll where sites can receive financial support. So please do contact us to learn more. But we do offer this also as at no cost to facilities. And we understand that, of course, there is cost associated with your time, but we hope that by not having an additional fee, that does help with getting started.
Thanks, Shayna. And can we put up the contact us slide one more time? That way, if anybody wants to reach out or scan the QR code for the jot form and visit the registry, we would encourage you to do so. We will hang on for any more questions here shortly. And like we said, once you fill out that jot form, we will be in touch and we will discuss next steps. Okay, looks like we do have a question from Joanne. If
Hello, this is Joanne from, I'm from Cooperstown, New York, with Bassett Hospital. Can you hear me?
yes, we can.
Okay.
Welcome.
We have been with this, with a stroke program and Get With the Guidelines for as far back as I can remember. And I just want to say, if anybody's considering going with Get With the Guidelines, it's a great registry. And it's a great way to collect all kinds of data that I don't even know how to collect it as yet, that there's just new things coming all the time. And we've had nothing but good outcome from our stroke patients with Get With the Guidelines. So if anybody's thinking about it, I would go for it.
Well, thank you, Joanne. We appreciate the the encouragement and the recommendation. We appreciate those thoughts. Did you have a question or just
No question. We
appreciate it. Good.
just want to say, if anybody's thinking about it, go for it.
Thank you, Joanne. Appreciate that.
That was an unpaid endorsement. Thank you.
Anyone else before we wrap up? We want to make sure we're capturing anybody's questions that they might have. We know we went over a lot of information today. Dr. Owens or Wong, did you guys have anything additional to add
No,
before
just wanted to thank everybody for attending. We know it's, hard to make time in your day for another webinar, but we of course feel the importance of this one urgently. And we thank you all for joining and hope that you will see the benefit in this registry and strongly consider joining. And thanks to everyone on the AHA team for all their hard work putting into this webinar, but also in the building of the registry. We know that you have years and decades of experience, and we're seeing that day by day as this comes together. So thanks to everyone on the AHA team as well.
Yeah, I'll echo what Anjali has just said there. We're very excited about this registry. We really see it as potentially transformational in the care of patients with hypertrophic cardiomyopathy, how to improve it, how to assess it. We see the spectrum of settings that patients receive their HCM care at, and feel that this is a way to standardize and improve the care across all of those settings. So again, we're very excited that you were interested as well. Thank you.
Thank you both. And so without any, it says, how can we get information regarding the guidelines in other in other areas to familiarize ourselves with the registry. Are you asking about specifically about the item, the CRF that's going to be collected, or about the other get with the guidelines? Looks like Nathaniel.
Nathaniel, maybe you're having a hard time getting off mute. We can go ahead and contact you offline.
Yeah, we will reach out. Okay, so that concludes our presentation for today, and we look forward to partnering with you and building a strong community committed to improving the outcomes for patients with cardiomyopathy, hypertrophic cardiomyopathy. Thanks, everyone. We appreciate it.